So management is a little controversial. You have some 5 to 6 critical parts in each stage, which we have to cover. But if you can see here, this is the cancer, and this is the mucosa, and it's just penetrating through the lamina propria over here. The end of the mucosa is the lamina propria. Under that, you have the muscularis mucosa, and then you have the submucosal connective tissue, the submucosal connective tissue, and then you have the muscular layer, which is like think of it as a gut, and then you have the serosa or the peritoneum, subserosa, and then you have the serosa. Now all these are peritoneally wrapped organs, so it will be hanging in the peritoneum, the colorectal cancer. Now, when it is carcinoma in situ or T1, T1 penetrates through the submucosa, T2 penetrates through the muscular layer, T3 touches the penetrates through the adventitia but does not penetrate through the serosa. T4 is when it penetrates through the peritoneum and crosses it. Now T4A and T4B means it has crossed the peritoneal covering, and T4B is, it invades the adjacent structures or organs. T4A again is again only peritoneum. And if it invades from here, you can see invading the other organs, T4B. N1 for colorectal cancer is that if the cancer is here, you have two to three regional lymph nodes. N2 is 4 to 6, and N2B is 7 or more lymph nodes. Now, this is important because management is based. Now, what's important is the stage groups. It's not just the TNM staging. So, in short, the easiest way to look at the stage groups is to look at N stage. So, if there's any lymph node involvement, N1 or N2, it would go to stage 3. Now, there you would in stage 3 divide it into high risk and not high risk. Okay, as long as there are no lymph nodes involved, it will be in stage 2. Okay, and then stage 4 is metastasis. So now here you will have to be able to differentiate between N1 and N2 and high risk or low risk features. So the secret hack here is that in stage 3 colorectal cancers, look for N1 or N2. If it is N2 or T4, then you consider it high risk. If not, you consider it low risk. Now, why is this important? Is because that's where you have your adjuvant post-surgery chemotherapy option, which is very significant. If it's low risk, you can give Capox for 3 months only. You don't need to give unnecessary chemo based on this idea pooled analysis. If it is, high risk, then based on this, you have to give Folfox or Capox based on the mosaic study. Okay, so if you're talking about the stage 3, N2 or stage, no, that's basically N2, which is stage 3, or we're talking of T4, N1, or something that penetrates the peritoneum. Basically, you look for high risk features or not, and then you decide if it's 3 months or 6 months of chemotherapy. Now, obviously, if it is deficient MMR in that subgroup for all stage 3, you will give chemo plus anti. So now, if you ask me, okay, stage 3, now we're giving adjuvant chemo in a stage 3 patient for either 3 months or 6 months. What are we going to do in the stage 2? Stage 2, if there are no high risk features, like what is the stage 2 high risk feature is where you have T4 in the stage 2 without having any lymph node involvement, or if you have an extremely poorly differentiated histology with lymphovascular perineural invasion, or if you have not examined 12 lymph nodes, then you are talking of stage 2 high risk cases. Okay, and here in stage 2 high risk, there is a quasar trial. Okay, and there's some pooled data that says that there is only a moderate benefit of adding adjuvant chemo in unselected stage 2. So you could give adjuvant 5-FU leucovorin single agent, or you could give capecitabine in stage 2. Now the thing is that if it's a low risk stage 2 where you have examined more than 12 nodes, then you can just do observation. If it is a high risk, you can consider 6 months of capecitabine single agent, just like triple negative breast cancer. And if it is a very high risk stage 2, then you should consider doing a oxaliplatin based regimen. And if it's deficient MMR, you can just have observation because they really do. Well, you don't even need adjuvant immuno. Stage 1, obviously, now we're not talking of any adjuvant treatment. So stage 2, we're talking of high risk and low risk. And stage 3, again, we're talking of high risk and low risk. In stage 2, when we're talking of high risk, we're talking of giving 6 months of capecitabine oral or 5FU based therapy. In stage 3, if it is low risk, we're talking of Capox for 3 months. If it's high risk, we're talking of Folfox for 6 months. And if the patient's unfit for oxaliplatin, then we will give capecitabine monotherapy. Obviously, if there's deficient MMR, you do the same regimen with atiso, like with any immunotherapy. So that was in stage 3. The important recent trial was the atomic trial where deficient MMR, where they gave low risk or high risk based on the regimen. But say, let's assume we're talking of stage 3 high risk in the atomic study where we're giving Folfox 6 with atiso without the bolus regimen and without the bolus FIFU regimens, and you just give Folfox, and 3-year DFS was 86 versus 76%. So this is adjuvant immunotherapy in stage 3 deficient MMR where you have the benefit. Again, now low risk and high risk, the same thing comes into place. So let's summarize again. Okay, when we're talking of colorectal cancer, the controversial points are about the risk status, but the lymph node status. If you have any lymph node involved, stage 3. If you have any lymph node involved, it is stage 3. When you have lymph nodes involved, stage 3, then you need to consider if it is low risk or high risk. N1, T1, T3 is low risk, and is high risk. In high risk, you need to give 6 months of chemotherapy on adjuvant basis. If it's in low risk, you can give 3 months trying to decrease the chemotherapy. It may not be very wrong to just give 6 months for a stage 3 patient. In a stage 2 patient, we're trying to down escalate the chemo. And in stage 2, as we spoke about, low risk and high risk. In stage 2, uh, what is high risk? High risk is if you don't have 12 lymph nodes, or if there's lymphovascular invasion or vascular invasion. So in stage 2 low risk cases, you can just do observation, and in high risk patients, you have 6 months of care box. So let's just get this very clear. And this covers the basic approach to the controversial adjuvant management in colorectal cancer. Metastatic, again, we'll do a different talk on that.